Hi, my name is Gabby Brower, and this will be my Unit 4 Case Connections presentation. So this is, like I said, my case connections for Unit 4. The first case I selected was case number 2. So a 4-day-old infant, patient A, is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy was a normal delivery, or the delivery was normal. The results from a newborn screening demonstrated a phenylalanine level of 6.6 milligrams per deciliter. The normal range for this would be 1 to 2 milligrams per deciliter. So a presumptive diagnosis of phenylketonuria was made and additional samples were obtained for further analysis. And the parents denied that there was any family history of PKU. PKU is a genetic disease, so yeah, you would look for the history in the family. So, first question is, as a consequence of this presentation, which amino acid may become essential? So as a consequence of PKU, tyrosine would become essential. Phenylalanine combines with tyrosine in order to make products such as melanin, thyroxine, and some neurotransmitters. Tyrosine must become essential because the phenylalanine can no longer be used to create the tyrosine. This is because the main mutation leading to PKU is with the phenylalanine hydroxylase enzyme. So without proper function of the phenylalanine hydroxylase enzyme, tyrosine cannot be created from phenylalanine, and thus would become essential and would be necessary for you to obtain tyrosine through your diet as opposed to making it using phenylalanine. So what are the potential causes of the presentation of PKU? So one cause of PKU is, like I said, a mutation of the phenylalanine hydroxylase enzyme, or the PAH gene. Which could lead to a mutation of the enzyme. So the phenylalanine hydroxylase enzyme, like I said before, is used to convert phenylalanine to tyrosine using BH4 as a cofactor. So any mutation to the gene for the phenylalanine hydroxylase enzyme would lead to a decrease in the enzyme's ability to catalyze this reaction, which would result in the accumulation of phenylalanine, and this would most likely be the cause of PKU. However, it's also worth mentioning that PKU is a genetic disorder. So on a deeper level, PKU is caused by a genetic mutation that would be passed down in the family. So both copies of the gene in the cell must have the mutation in order to for the individual to present with PKU, which means that the parents would most likely both be carriers of the mutation. And in this situation, it seems like they do not actually know that. So another infant, patient B, is being evaluated for suspected PKU. The BH4 loading tests are performed on both, and the results are shown right here on this chart. So the BH4 loading test is BH4 tablets are dissolved into water and administered 30 minutes before the meal. The blood was drawn before the BH4 was consumed, 4 hours post-consumption, and then 8 hours post-consumption. And then from here, the phenylalanine levels are determined. So To summarize the test, first just beginning with BH4 is a cofactor. It's tetrahydropyotyrene, and it is required for the metabolism of phenylalanine, tyrosine, and tryptophan. So this is that, let's see, here it is. This is that reaction down here. BH4 is required for this reaction to take place. So when BH4 is administered to someone who has PKU, I would expect there to be no change or an increase in phenylalanine. And when B4 is administered to someone who does not have PKU, I would expect a decrease in phenylalanine levels due to the additional BH4. Sorry. So at the ingestion of BH4, phenylalanine levels of the two patients are similar, if not the same actually. Looking at patient A to begin, which is the blue here, after 4 hours after loading, her phenylalanine levels have increased slightly, and at 8 hours, patient A's phenylalanine levels have increased slightly again. Excuse me. So looking at patient A's results, I believe this confirms that they do have PKU. Just looking from loading to 8 hours, patient A's phenylalanine levels have increased, which means that the addition of the additional BH4 did not increase the conversion of phenylalanine to tyrosine. And as previously mentioned, this is most likely due to mutation in the phenylalanine hydroxylase enzyme. So this is the opposite of what we see happening with patient B. From loading to 4 hours, patient B's phenylalanine levels have decreased slightly. At 8 hours, patient B's phenylalanine levels have dropped significantly. So I would expect that these results for patient B, they've happened because they do not have PKU. So when the BH4 is ingested, it begins allowing phenylalanine to be processed through to become tyrosine. So it's a cofactor for that reaction, so it's helping it move along. So it's possible that patient B could have had a BH4 deficiency, as these symptoms mirror or present similarly to a deficiency in the phenylalanine metabolism. So the second case I chose was case number 3. So for case number 3, a 47-year-old male has severe pain in his right great toe. He is unable to bear weight on the toe, and upon coming to the clinic, there's no apparent trauma. He reports that this pain started the previous night and continued to increase. Based on the findings of the physical exam as well as the lab findings, he was diagnosed with gout. So gout can be caused by several different mechanisms, and blood samples are drawn and the urinalysis is performed. So this is the blood test and urinalysis presented here in this table. So what is the best explanation for the presentation of gout in this individual? So the first one we'd look at, first option is an overproduction of purines. So if the patient were to have gout due to an overproduction of purines, I would expect to see a high level of urinary uric acid. And with this mechanism, there's also a relationship with von Gierke's disease. Von Gierke's disease is a deficiency in the glucose 6-phosphatase enzyme. This means there's an accumulation of the glucose 6-phosphate, and for this specific situation, it's oxidized via the pentose phosphate pathway. This leads to an increase in the amount of ribose 5-phosphate produced, which leads to the overproduction of purine bases. This is why, with this mechanism, I would expect to see a high level of urinary uric acid. But that's not the case with this patient. He actually ended up with lower levels of urinary uric acid, so below normal levels of urinary uric acid. So I do not believe this is the mechanism that would have caused his gout. So the second option is a decreased salvage of purines. So similar to the overproduction of purines, if a patient were to have gout resulting from decreased salvage of purines, I would also expect to see a higher level of urinary uric acid. This is occurring because there's a deficiency in the hypoxanthine guanine phosphoryribosyl enzyme. This enzyme is responsible for salvaging purine nucleotides. So with the deficiency in this enzyme, we would see a buildup of uric acid. And with this enzyme, there's also neurological issues that could present. And so with this patient, there are no reported or observed neurological issues, as well as the level of urinary uric acid is below normal again. So I do not believe that this is the mechanism of this patient's gout either. So the third option is a decreased urinary excretion of uric acid. So I believe this is most likely the explanation for the presentation of gout in this patient, as the patient had below normal levels of urinary uric acid, which is consistent with this idea of decreased urinary excretion of uric acid, meaning uric acid would be decreased if the patient had low levels of urinary uric acid. By process of elimination, I would deem this to be the best possible explanation for this patient's condition. However, I do think more information would be important in order to be completely certain. Information such as alcohol consumption or details about his diet that would indicate a very low level of purines being consumed, as that information would just help us to be more certain about this being the correct mechanism. So some additional information for this patient. We find out that he recently switched from diet to regular soda, and that he drinks about 4 to 5 liters of soda per day. And then an important note is just that fructose or soda contains, typically the sugar is fructose or high fructose corn syrup. So what is the potential impact of this dietary modification on the presentation of his gout? So there is a connection between fructose and uric acid. Essentially, fructose increases the conversion of ATP to AMP. AMP is part of the uric acid synthesis, so uric acid levels rise. So on a biochemical level, according to De Oliveira and Berini, upon ingestion of fructose, it is phosphorylated to fructose 1-phosphate, which is shown right here. Then using the aldolase B enzyme, fructose 1-phosphate is lysed into dihydroxyacetone phosphate and D-glyceraldehyde. So the first reaction, the phosphorylation of fructose, happens quicker than the second reaction, the lysing of the aldolase B enzyme, which is resulting in the accumulation of this fructose 1-phosphate, and it also decreases the number of available phosphates. So ATP formation is slowed due to this low availability of phosphates. So this leads to higher levels of AMP, which leads to higher levels of uric acid, and all of this means an increase in fructose consumption could have adverse effects on this patient's gout. So here are my references, and thank you for listening.